have across the globe, and their expertise drives across microbiology governance, surveillance, preparedness, health system strengthening. Before I move on, I would like to briefly introduce GET. The Global Emerging Pathogens Treatment Consortium was founded during the 2014 West African Ebola outbreak, and we are legally registered in Nigeria, in Accra, Ghana, in Sierra Leone, and in the United States of America. Our primary purpose is to develop African-led and Afrocentric strategies within an international context and to effectively address emerging biosecurity threats. We collaborate and partner with many organizations, both within and outside Africa, and we continue to champion African-led research, capacity building, biosecurity, policy support, and health system, and strengthening the health system through One Health. So right now, we are going to be moving on to our very first speaker for today. And I would like to introduce, we have 5 distinguished speakers amidst us. Before I do that, I would like to share some housekeeping rules. Please use the chat box to share your reflections. Let us know where you're joining from, your name, and wherever you're joining from. Submit your questions through the Q&A feature, and we will address them during the interactive session after all our speakers have presented. And this session is also being recorded, and it will be uploaded on our YouTube channel at Get Africa after the webinar. Also, certificate of participants will be issued to all registered participants. If you have friends and colleagues who are yet to be here and you think they can participate, they can learn 1 or 2 things from this webinar, especially from our speakers, please share with them, share the link with them, and let them join. So right now, I'll be moving on to our first speaker for the day. Our first speaker is Professor Bruno Gonzalez Gon. And we also have Dr. Harma, we have Dr. Heba, we have Dr. Adliam here, and Dr. Afinish Amir. So right now, I won't be reading Professor Bruno's biography because of our time. We have 5 speakers and we're trying to manage our time as much as we can, but his biography will be pasted in the chat box. He's the head of the Antimicrobial Resistance Unit at the University of Madrid, and he'll be speaking to us about the operationalizing the One Health approach, practical strategies to strengthen AMR prevention and control in Africa. Professor Bruno, thank you so much for honoring our invitation. You now have the floor.
Now you can hear me?
Yes, we
Can you hear me? Okay, and you see my presentation. Okay, fine. So thank you very much. I wanted to thank the organizers, the GET Association, for letting me form part of this great webinar. As I'm the first speaker, and not everybody is super related to antimicrobial resistance, I will give a short introduction about what I think about One Health and also about antimicrobial resistance and how we made it to be in this critical situation in which we are today. And then I will give you some thoughts about what I think and about my experience in Africa. So my name is Bruno Gonzalez Son. I'm professor for microbiology in the Complutense University of Madrid. I'm also chair of One Health in Una Europa, which is in a European alliance of different universities. And well, I form part of different groups. Also, I advise the European Public Health Association. So with no more delay, I will start. So if you have a look, this is the amount of human beings that we are have been on Earth and we are on Earth. And if you see there, oops, something has happened there between the 19 whatever and something that completely made the human population completely exploded. And we know perfectly today that there are three reasons why this is the case. This was the case. It's water hygiene. It was probably one of the main reasons why this has happened. The other reason is vaccines, the use of vaccines, and the subject that we are dealing with today is the discovery of antibiotics. So thanks to the discovery of antibiotics, among others, the human population has been healthier and healthier and has created this ecological disaster. So we have many humans today on Earth, and which is a problem, but okay. But and this is because we've been so fruitful and so good in our health research that now finally we have this problem of superpopulation. I will not talk about the problems that we have today, but antibiotic resistance is one of them. But when we talk about about all these human beings that we are on Earth, we have also to consider that we are not there alone, because we are all colonized externally and externally by millions and millions of bacteria. How many bacteria? Per gram of our intestinal content, we have as many bacteria as human beings are on Earth completely, but each gram. So which means millions of bacteria in our intestinal content, and these bacteria have not been able to adapt themselves to our intestines and on the intestines of all animals, but also to the intestines of all different animals on Earth, and also to all the ecosystems on Earth. So there's no single ecosystem on Earth that is not completely colonized by bacteria that have this capability of adapting very well to any ecosystem. So we think of ourselves always because we are so egocentric, but the fact is that the real drivers of life on Earth are really bacteria. So how have bacteria really conquered all these ecosystems? So the answer is not peacefully. Not peacefully. So bacteria have learned through all these years to produce molecules that kill other bacteria, the competitors, and other bacteria have also learned with in all this time to also defend themselves from these molecules, which is, as you know, probably antibiotics. So this is happening for many years already on Earth. There's nothing that is completely new. For how long is this happening? So this is more or less happening for 3,500 million years. Bacteria fighting with each other are producing antibiotics and also defending themselves from antibiotics. So the war antibiotics and bacteria is happening since we know that life exists on Earth, because the first living beings on Earth were already very similar to bacteria. And we are only here, you and me, we are only here for the last 200,000 years, 300,000 years. So we are just newcomers, but the bacteria have always been there and they will always remain here. And we started just to control bacteria less than 100 years ago, as you know very well, when Fleming, this strange thing that he didn't even know the name, fell into his plague. And into his plate when he went off for vacation, and he saw that this Staphylococcus aureus that he was working with grew less well in the vicinity of this strange thing that normally was falling into the plates of many microbiologists, but nobody has ever made this observation. So the important thing was the observation of Fleming, and then he said, okay, I will not work much more with my Staph aureus, with my bacteria. This is the original plate. I will work with this strange thing that I don't know even the name, which is producing something that is hindering the normal growth of my bacteria. And with that observation, he has done what for me is the greatest discovery of human history, and that is the discovery of antibiotics, because all modern medicine is based on the fact that we control bacteria. All surgeries, all transplantations, and putting in the example of the National Transplantation Society of Spain, which is the best in the world by number of transplants, etc. So all the modern medicine is based on the fact that we control bacteria. What happened is that after Fleming, we all discovered all the antibiotics that we know today until the 70s or 80s, where for each bacterial infection, we already had sufficient antibiotics. So for every bacterial infection, we could use like 2, 3, 4 clinically different antibiotics, and all of them are working well. So it's true that we had enough antibiotics in the market, and that the industry concentrated in other molecules. On what molecules? For example, molecules against HIV, what was a super pandemic in the 70s and 80s, as you know very well. And thanks to the fact that the industry concentrated on other molecules, for example, HIV, today, the life expectancy of an HIV patient is the same as of an HIV negative person. So which means that they did well in that, but the fact is that it's 30 years, so 3 decades, that we just don't discover a new family of antibiotics. Everything that comes out to the market is like derivatives of penicillin, so carbapenems, etc., and derivatives of clavulanic acid. So this is what we are, what the strain and different modifications of antibiotics that we know is what we are finding today. But it's 30 years that we don't find a new family of antibiotics. So today we have a lot of resistance because, as I told you, bacteria adapt so well to every different ecosystem. So they adapted to the presence of antibiotics. So we have a lot of resistance and no new antibiotics in the market. Then we started to use antibiotics in humans, animals, and also in some plants, because all these kingdoms also have the bacterial diseases. Don't forget, when we talk about antibiotics in animals, many people think, oh, okay, the food is full of antibiotics, which is true in many parts of the world. In Europe, for example, we banned the use of antibiotics as growth promoters in January 2006. We banned it in the US in 2017, or at least the antibiotics that are used in clinical human practice. But in many parts of the world, and in many parts of Africa still, antibiotics are used as growth promoters. And also, as in many different parts, the food is not full of antibiotics, which is the case in Europe and in highly developed countries, because when an antibiotic is given to an animal, there's a time that you wait until this antibiotic is metabolized, and then the food has no rest of antibiotics. But in many parts of the world, and it's an important part of also in Africa, products of animals, that even the meat comes to the market with high antibiotic levels. And this is something that we have to take into account. Maybe this is an important driving force, the food full of antibiotics, that makes that antibiotic resistance is developed faster and faster. The fact is by using antibiotics in humans and animals, the antibiotics actively also come out of the patients through urine and through feces. And the fact is that the world is full of antibiotics and full of antibiotic-resistant bacteria. And we do, as you know, maps in Europe to see how many antibiotic-resistant bacteria we have. And this is, for example, E. coli and fluoroquinolones. And antibiotic resistance is out of control, not only in Europe, but also in many other parts of the world. Here we see, for example, in the European geographic region of the WHO, how we have resistance to fluoroquinolones in E. coli. And you see that we have levels up to more than 50% in many places. Also, E. coli resistant to carbapenems, also Klebsiella pneumoniae resistant to carbapenems, Pseudomonas aeruginosa resistant to carbapenems, and Acinetobacter also resistant to carbapenems. So we have high levels of resistance in many parts of the world, as you can see here in the eastern part. I wanted to thank Danilo from ICARS, former WHO, but now from ICARS for these slides, and also MRSA. As you can see, the levels are very high, but not only there. Also in Latin America, we see carbapenem resistance. This is the latest report. I'm waiting for the newest data, but we have more than 50% of resistance to carbapenems in some regions of Latin America, which is not very good. And most of you have probably, but although those of you that are not really working on antimicrobial resistance, there's a report from the WHO, from GLASS, that just came out a couple of weeks ago, where we see that most of the bloodstream infections, especially of E. coli and Klebsiella, are resistant in this continent. And this is very important. Only 1.3 of clinical laboratories can perform proper bacteriological testing. And this is probably one of the most important reasons why or one of the reasons also why, from an operational point of view, we are not ready to fight really antibiotic resistance, because the capacity of the labs, not only capacity building, not only of the people, but also from a material point of view, and we can discuss that maybe later, is not enough. And less than 60% of the countries report surveillance data, and we know very well, and this has also been demonstrated here with this an analysis of this report, that the more surveillance you have, the less resistance you have. So in the countries where we don't perform surveillance, we have higher resistance levels. So this is probably one of the another bottleneck that we have in the Africa continent. And as you can see here very well, antibiotic use is increasing. So you see in the upper line, high income countries, low-income countries and developing countries in the middle. So we are constructing hospitals in Africa. We are constructing hospitals in Latin America and Southeast Asia. So the economy in many of these countries is boosting. And this means that we are increasing the use of last resort antibiotics or hospital antibiotics in these regions. And this is another reason why it's important that we start to tackle it, because as you know very well also, as soon as in one part of the world there's one antibiotic resistant bacterium or gene that is very proficient, it's able through planes and also through migrating birds, etc., to disseminate itself through the world. When we talk about antibiotic resistant bacteria, we talk mainly about this list that we started to do in the WHO a couple of years ago, and now in 2024, and we published it again. And there you see we're mainly talking about the most important problem that we have in general is E. coli, Enterobacteria, and also Pseudomonas, Intercinetobacter, resistant to carbapenems and third-generation cephalosporins. But we included now Mycobacterium tuberculosis, and I will come back to this later, because tuberculosis is the disease that killed most, infectious disease that killed most people in the history of humanity. 1,000 million people have been killed through in history of humanity, and it's still a very important problem. We have extremely drug-resistant bacteria, as you know very well, but there's maybe some hope, as I will tell you later. I'm talking about bacteria and resistant to antibiotics, but we included already a couple of years ago also the fungi. So fungi and fungal resistant, which is in some places of Europe very high. In some other places we still don't know, and there's a lot of work to do. Because we still don't know how to do a proper antifungogram. The identification is complicated. So this is probably like a black hole where many things are happening, and we should be knowing what is happening with all this fungi and the antifungal resistance worldwide. And here's the mortality due to antibiotic resistance that you know very well, which we estimated more or less 1.2 million deaths per year worldwide. And with COVID, as you know very well, there was more antibiotic resistant antibiotic use, and with more antibiotic use, with also more antibiotic resistant bacteria. So this also boosted, even if we were already fighting since 2014 against antibiotic resistance, this boosted also resistant bacteria all over the world. So the question is, how can we preserve antibiotic resistance or the action of antibiotics? And one of the ways that we think that we should do it is by thinking with a One Health approach. So we know that bacteria don't stay in the patients or in the animal patient or in the human patient. They also make it to the environment, antibiotics and the bacteria, and there's a flux of bacteria between humans, animals, and the environment. And this transmission is probably an important reason why this antibiotic resistant bacteria flow so easily. And we have not been able to work from a One Health perspective for many years because of this, because we are pointing one to each other, the pharmacists pointing to the medical doctors that were not prescribing very well, the medical doctors prescribing to the vets that were using too many antibiotics in animals. So that was this blame game. We were stuck in the blame game for many years until we now realize that we really have to work together, and each profession has to work on its specific field to try to fight against antibiotic resistance without pointing to the others. You are not doing enough, you are not doing this. So it's very important that we sit down in the same table and stop blaming to each other. And in some countries, in Africa also, but also in Latin America and Southeast Asia, we are still stuck there. We have national action plans, but still they are sometimes organized by a specific ministry, health or agriculture, and then they're pointing to the others. It's their fault. We're doing the things well. So it's very important to come out of this blame game and start working together, because we have the same diseases. And here, for example, you see a human being and an animal having a suppurative conjunctivitis. They both need antibiotic treatment. So we need antibiotics in both. We have to treat also antibiotics and use antibiotics in humans and also in animals. And that's why we have to just work together, because we have to use them. You know very well that many of the human diseases are zoonotic, so they're going from animals to humans. So also resistance there is flowing from one place to the other. And I will show you straight away how we are doing it. Many of the diseases are coming directly from animals. Most of the emerging infectious diseases in the world, at least 75%. We talked about Ebola at the beginning. That was the origin of the Gates Foundation. So Ebola obviously comes from humans, but also from animals, but also COVID, also HIV, influenza, etc. We have 5 new diseases in the world every year, and 3 of them are coming from animals. And obviously, all these diseases can be used also potentially in bioterrorism. So it's thanks to maybe well, probably thanks to COVID finally, we are working with all in all the pillars of antimicrobial resistance in the One Health perspective, which means World Health Organization, FAO, World Organization of Animal Health, but also the United Nations Environmental Program. So all partners are now governing and working on antimicrobial resistance. This is what we call the quadripartite. I hope that all of you master. And in this context of One Health, we published already 2 years ago the medical important antimicrobial list of the WHO. It was called the critical important antimicrobial list, but we called it now this time the MIA list. And in this MIA list, you can, I propose that you use, if you want to tackle antimicrobial resistance and antibiotics in your own country, that you use this list, because here we've classified antibiotics that are authorized for human use only, for animals only, and there we've classified all the antibiotics from in highly priority, critical important, or important antibiotics, and you can use this list in your country, in each different country, to see on what antibiotics you should maybe focus your efforts to try to limit them in your country. So this is really a new version that we published. As I said, the most recent one, and I really recommend you to download it and to use it. And obviously, all the research that we're doing worldwide, we do it through the One Health perspective. And because we have this flux of when we use antibiotics in humans or animals, it goes to the sewage water, to food, to natural water, and from that directly also to humans. So there's this complete life cycle from humans, animals, and the environment. So as I said, the world is full of bacteria and antibiotic-resistant bacteria. Is it true that the bacteria really make it and flow from animals to humans? Yes. This is, for example, the case of Salmonella enterica. There's still more or less 70,000 deaths by Salmonella enterica. I'm not talking about Salmonella typhi. I'm talking about only Salmonella enterica. And all the Salmonella enterica are directly flowing from the intestine of an animal, sometimes to the food and sometimes directly to the intestine of a human. So yes, bacteria directly make it from the intestine of animals directly to the intestine of humans. So yes, that is the One Health approach. We need it absolutely. Although in some places, as you can see, the animals are very far away from human beings, and this is, for example, a picture from the United States. But in some other regions in the world, the contact of humans and animals is very, 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 very narrow. And this is also probably one of the reasons why we have all these Salmonella enterica cases in this part of the world, but it's more or less the equator, because the contact of humans and animals is very strict. So every antibiotic that you use here in animals makes resistant bacteria to the animals. And as you see somebody's washing the hands there, directly goes to the human, and vice versa. If this man is coming from a hospital, he's sharing his bacteria with all the animals. So there is in some places of the world, depending on the place, more or less flux of bacteria between different bacterial species. In Europe, for example, we are now starting to concentrate on companion animals, because half of the Europeans have companion animals, and there's probably a flux of bacteria there. But in some other parts of the world, and mainly in Africa, it's probably the flux is higher between food-producing animals and humans. And here I wanted to give you just a short example of a study that we did in Ghana. So we're working for many years already in the northern region of Ghana. So you have the southern region like Accra, etc. So there's a lot of attention given there. Also in the middle part of the country, Kumasi. But in the northern region, it's a agricultural region. It's the less favored. So there we're working there, and we have analyzed the resistant bacteria that are coming out of the hospitals, and we see from the hospitals, and we see high levels, 10 to the 5 bacteria resistant to carbapenems, enterobacteria. So we see that really this is going out of the hospital and really touching the population, because it's the wastewater of the hospitals comes after and finishes and finally is open wastewater, and there's a direct contact with humans, animals, and also with the environment. So there's probably also we have to take care in Africa with the wastewater of the hospitals. Just to finish, I am optimistic, because I think that we are doing a couple of things that we are doing and we can do well. We have more attention than ever to antibiotic resistance in general in the world, and I think that is good. And also from the One Health perspective, this was not the case 15 years ago when I started. So I think this is very good news. we have to take very much into account that sepsis and malnutrition is affecting many people in the world. It is really shortening the life of many people. There are many deaths related to morbidity, and especially in children in low and middle income countries. I think that capacity building is very important. So, because as we said, surveillance, we are only doing in 1.3 in countries in the world. Be careful with the new machines that we buy in Africa, because I see many donations of many, that will not talk about anyone, giving donations of machines, but that finally a red light opens and then the lights and then the machine, and then the machine doesn't work anymore. So be careful with these donations of high-end modern machines. Sometimes capacity buildings and things that are more adapted to the countries are more important. This is what we call white elephants. We don't always need new antibiotics. Sometimes hand washing saves 30% of the lives in the hospitals. And as you can see, hand washing helps, especially in low and middle income countries. It saves life. This is how the amount of deaths that we can reduce just by washing our hands. And vaccinations. By using vaccines, we prevent diseases. If we prevent diseases, we use less antibiotics. And so vaccination is probably the most important thing in children that we can do today in Africa. Just by vaccinating, and this is a new vaccine that I hope that will come out in a couple of years. We are testing it from Spain, a new vaccine against tuberculosis, and we have very good results. So probably this will save many lives worldwide as soon as the new tuberculosis vaccine will come out of the market. Just by using vaccines, we can reduce 22% of the antibiotics that we are using worldwide. So this is where we report from the WHO. So I think that's important. Vaccinations is probably the most important thing. And also, don't forget, and this is my last point, access. So we are talking about antibiotic resistance and using too many antibiotics, but in many parts of Africa, access is the problem. So we have to improve the access, and people die because they don't have access enough to the antibiotics. So this is why we also have to train our prescribers to prescribe properly and to work together. And with this, you can contact me anytime. I wanted to thank you for your attention. I hope that you enjoyed it, and whatever I can be helpful, or you think that I can answer or reply or help you, you just let me know. Thank you for your attention. Thank you.
That was a beautiful presentation. Thank you, Professor Bruno. And thank you for starting from scratch with us, explaining what antimicrobial resistance is and that it has been in existence since even before we came around. And thank you for mentioning that it is everybody's business and it's not just one person's own one. We should stop shifting the blames to one another. We can embrace the approach of One Health more and put some things in place to ensure that it works. So thank you so much. And because of our time, we quickly want to move on to the next presenter for today, in person of Dr. Alma, who will be speaking for just 20 minutes because of our time. And we also have Dr. Eba coming next after her for 20 minutes as well. I would not be reading a biography because of our time, but it will be pasted in the chat box. Dr. Emma is a senior consultant of pediatric infectious disease and IPC at Oman. So thank you so much. And she'll be speaking on strengthening AMR response capacity through innovations in infection prevention, surveillance, and diagnostics. Dr. Emma, you're welcome, and the floor is yours. Thank you.
Thank you very much, and thanks for the invitation to speak in this webinar. Actually, Bruno did a great job and set it up the scene for me to go with my talk. So are you seeing my slides?
Yes.
Yes.
For some reason, they are not moving for me. Okay. Okay, here we go. So I'll be talking about strengthening AMR response capacity through innovation in infection prevention, surveillance, and diagnosis. And I'm quoting here the talk that was given by Maya Amor, the GLG head, who have called that we are setting the scenes now for actions, and it's time to move from declarations to implementation. Actually, this resonates well with the WOW week, where we are calling to act now, protect our present, and secure our future. So we need really some practical solution. We need to guide people on what they can do practically and where they can start. Of course, that cannot be done without having an insight into the past while we are observing the present and looking for the future. We have to see why previously there were no actions or partial actions before we decide where to move our current capacities. And the word innovation have been used so widely that we really need to be concise when we define innovation and understand what does it mean in the context of AMR. And for this particular presentation, people might wonder why acting on diagnosis, surveillance, and IPC for AMR in particular, and whether there is any political enablers for countries and resources. And finally, I'll be giving example for some innovative approaches. Of course, all of that is driven by the threat of the AMR, the threat that is unfortunately predicted to be a death of 10 million people by 2050. The majority would be in Asia and Africa. So if there's any two continents which AMR and acting on AMR should be a top priority, it would be Asia and Africa. So what do we mean by innovation? People, when they talk about innovation, their minds goes into electronic data, into AI, when it's actually the continuous development and application of breakthrough ideas, technologies, and system improvements that reinforce countries' ability to prevent, detect, and control infectious threats. That includes the AMR. It transforms knowledge into action. So innovation, it's all to do about how we do that transformation from knowledge into action by enabling stronger surveillance, smarter use of antimicrobials, rapid response capabilities, and more resilient One Healthcare system that safeguard communities now and in the future. Well, Bruno has beautifully went into this, the One Health concept and how AMR goes between human, animal, and environment. And this resonates very well in the environment of the hospitals, not only by patients. Hospital setting have different kind of people who comes into it, between visitors, healthcare workers, which is occupational health, and also the patients who are immunocompromised and vulnerable for any infection. So it's a perfect setup for the spread of infection and for moving it into communities, and also for communities to bring infections inside the hospital environment, which makes also this a perfect start where we can do surveillance and bring data for action from within the healthcare system, and also convert this data into actions through infection prevention and control. So this plays very well. We need AMR surveillance. AMR surveillance, 3 parts. It's the MDROs, incidence and prevalence, the antimicrobial usage, and if there is reporting of a newly emerging pathogen. But to do that, you need diagnostics. And this diagnostics, and again, thanks for Bruno, he has beautifully shown that, needs to be affordable, accessible, accurate, and also align with standards, because you need this to be comparable between hospitals within the same country and also globally. And you need all of that to be integrated with infection prevention control, because it's the system set up in the hospital for surveillance, and mainly the surveillance of healthcare-associated infections. So when AMR is not coming from the community, the AMR has been acquired in hospital that goes into the healthcare-associated infections, and this also drives the care bundles for IBC, the improvement in the environmental hygiene, also in addition to the instrument and devices which can also harbor the antimicrobial resistant organisms. But we also need the integration to be at different levels, integrating AMR surveillance into healthcare-associated infection surveillance by making the AMR data part of each healthcare-associated infection investigation, use shared priority pathogens, and integrate AMR matrix into healthcare-associated infection dashboards using this preferably the same surveillance infrastructure, which manage a lot to provide capacities without the need for extra costs or extra capacities. You are using the same task force, you are using the same capacities within the same healthcare institution, but you need the help to make that integration so that the data can readily reflect the burden, the impact, and what is the drivers of the spread of antimicrobial resistance. Standardization makes it meaningful. It identifies also reservoirs, risks, priorities, and gaps within institutions and also within countries. And this can be very well later on utilized for communication and for research and innovation, especially if it has gone extra mile to be molecular surveillance. Is there global enablers? Yes, a lot have been done at a political level to enable us to advocate for implementing systems for AMR surveillance and IPCs. And this chart here shows some of them. I would not go into the details for the time purpose, but when it comes to surveillance and IPC, we do have the UN resolutions where now moving from 2016 resolution into the one that was in 2024 with indicators that is related to the mortality and to the impact of the control of AMR. Global policies are there and strategies, including the IPC global strategy, also international legal accountabilities and frameworks, high-level political advocacy. Surveillance systems are set like glass and also in the other sectors. Infection prevention and control also have been, there are a lot of guidelines, including the surveillance guideline for healthcare-associated infection. And we do have the monitoring frameworks and the support with the definitions and the methodology. Also now with the move after COVID in the era where surveillance should also benefit as an early warning system, I think this is also a very great call that we need to move with innovation so that we can detect the resistant gene earlier on. And then based on that, we can develop solutions, whether it was preventive solutions or management solutions in the form of drugs. Of course, you know that developing also early warning system would help to prevent disasters and outbreak and future pandemic. And the whole innovation come from looking into sources where we can get informations earlier on before it comes and reach to a disease and it present as a human health factor. This is illustrate what have been happening at a political level, starting from developing the Global Action Plan, first in 2015, and then the first UN General Assembly for the AMR in 2016 with the declaration of the Global Action Plan. And next in 2024, the most recent also assembly, which came with the indicators. But how is that translated in the reality? We still have situation when it comes to the countries reflecting on, for example, the healthcare-associated infection surveillance. In 2023 and 24, 50% of countries have a national strategic plan for HAI, which is a great improvement because we used to have only 43% in 2017, only had a system but not actually a plan. Is a plan enough? Of course not. We are also assessing whether this plan is funded and whether it's implemented. But there was a great move, and this have been observed from the self-reporting of countries in time of the capacities for the healthcare-associated surveillance. Also in times of the NABs and having fund for the NABs, there was a great move, an increase from from figures in 2017 to 2024, as has been shown by the follow-up report by the WHO. Recently, also in the World Health Assembly, there was priorities set and operational priorities were set to tackle drug resistance. And that include as a priority one, the prevention of infection through IPC component, especially WASH and vaccines. Priority two, which is the universal access for affordable quality diagnostics and appropriate treatment of infection. And three is the strategic information science and innovations, which refer to the surveillance and diagnostic, of course, as a start of it, and the effective governance and financing of those. The UNGA 79th was remarkable in that it had set targets for country to work with the AMR control plans, which is the reduction in the death related to AMR by 10% in 2030, and have been setting up certain indicators for that. For example, in human health, the use of 70% of human antibiotics should be from the access group, and WASH services also should be upgraded, as well as other indicators, and the announcement of the fund of 100 million in that meeting. Now, how do I convince my countries, and where's the action that is related to countries versus to the global umbrella of the organization? And this have been shown very beautifully in this implemented strategies, operational priorities. And as you can see, for countries and member states, WASH, IPC, and EPI is their area of action. Also, stewardship, diagnosis, and integration in the primary healthcare system, surveillance of AMR and AMU, and integration of the AMR surveillance into research and innovation. This is from the work on the Global Action Plan, the new one, which is expected to be released at the beginning of 2026. So strategic objective 2 is all to do about strengthening surveillance systems and diagnostic networks to inform effective evidence-driven AMR policies and action across all sectors. And it has beautifully said it that surveillance should be across all pathogens, across all sectors, AMU in human, animal, and environmental industries, technology and molecular to be used, and also should be aligned with regional and international surveillance system. And there is a plan to do a global integrated surveillance system across the 3 sectors. But remember that, to be part of this global surveillance system, the work should be starting at a national level. The other remarkable thing is the global strategy on infection prevention and control, especially the strategic objective 5, which is calling for data for action. And there is indicators for those strategic directions, which is for at a national level, establishment and strengthening national IPC monitoring system. The key too is establish and or strengthen the national surveillance system for AHI with the AMR. At facility levels, also making implementation plans to provide resources and achieve WHO minimal requirement for HAI surveillance. So you can use all of these enablers from the global political agendas in your countries to drive the capacities forward. And noting that there's targets for countries and at a global level, increasing the proportion of countries which is doing HAI surveillance to 30% by 2026, 50% by 2028, and over 80% by 2030. And there are nations who can also go into having a national target to reduce HAIs and have achieved, or those who have achieved national targets on reducing HI with extra bonuses. At level of facilities, the HI should be 30% for of the facilities in each country, 50% by 2028, and over 80% by 2030. This is not also separated from the research agenda. In fact, it's a priority of the antimicrobial research agenda priorities, the prevention, and the diagnosis, which also goes into the surveillance. Now, data is good, but we need data for action, and we need to manage data in continuity. And to be able to do that, we should overcome the constraints, which is the weak infrastructures, data standardization and sharing issues, resource and funding constraints, and the limited coordination, not only between sectors, but at times and sadly, historically, silos within the healthcare sector itself. And I think here, and talking about Africa specifically, surveillance can be supported by strengthening the legislation and regulation. For example, making AMR and AMU notifiable, monitoring antimicrobial consumption, and allowing data sharing, and strengthening the laboratory and epidemiology capacities. Tools and training of international partners also are available. You have a great asset with the African CDC IPC legal frame, which is a big enabler for you in the AU. I'll give quickly an example from Oman. And this is just to show you we have set it up initially OMAS, which is Oman Antimicrobial Surveillance System. And now we are joining it with the healthcare associated infection system. This have been enabled by the presence of IPC programs across the country in primary care and in hospitals. Also, the implementation of the program across the country with national lead. And we have a training and educational system that integrates the national and healthcare facilities with also academia. So we have modules for training in infection prevention control for health students. That is also electronic and a platform that can be accessed for the theoretical knowledge, and then they go for the healthcare facilities to do their training on hand hygiene and PPEs as well. So this system has allowed us to implement infection control across the healthcare workers and to make it everyone business, which has been reflected in the way they report healthcare associated infection, and we do the surveillance for it. We are using surveillance manuals that is ready-made from the GCC and also bundles for the same healthcare associated infections, standardizing the methods across the country, and also standardizing the tools. Initially, we used the annual report for the IPC, and we embedded in it Excel sheets for that enables the IPC workers to collect the data, and then it gets analyzed through made-up formulas within the Excel sheets, and they share it with the national. And in the national, we make the whole national analysis. So then at the end of the year, we produce the infection prevention and control annual report. Moving from there to the electronic platform would help us to make dashboards and to drive the data more instantly. And this have been possible because we have the healthcare system, the healthcare charts electronically, and we are using that along with the lab charts in integrating them so we can drive electronic-based healthcare-associated infection surveillance along with the AMR. This is another thing that I got to know it during a recent meeting, that MSF is also having an anti-biogo, which is a app that can be used in countries where there are limited lab capacities to interpret the data of the antimicrobial resistance and give reports that can serve patient care. And this can be accessible also for free. Whole genome surveillance is the future, and another innovation that is great because it also can link the different sites where AMR can be hidden and also show relations and can help in management of the outbreak, but also can provide data for innovative new drugs and vaccines. Of course, going for the environmental surveillance, mainly the wastewater can be utilized, especially in hospitals waste and also in the environmental waste, and drive some data prior as an early warning system if there's new genes coming up, so it can be prevented through new modalities of prevention, vaccines, and or the medications or some environmental solutions. So what do we suggest at the level of the AU member? Conduct a legal gap analysis utilizing Africa CDC legal framework, 6 IPC domains, establish a stationary national IPC programs with a protected budget line, mandate facility level reporting of HAI and AMR data, integrate IPC requirement into licensing and accreditation, define your workforce standards, and you have great asset from WHO standards and also the ICANN, adopt WASH and safe infrastructure standards in all facility, and utilize the CDC for legal drafting and cross-border coordination. It's a moment for Africa. And I think having the 5th high-level ministerial meeting on AMR is a great opportunity that you can build on it a lot of capacities for Africa and advocate for it. My last message, high-quality surveillance is not only about collecting data, it's about transforming this data into action that protect patients and strengthen healthcare systems through robust IPC programs. And it's the moment. Don't delay it. This is the perfect moment. You have strong enablers, including innovative approaches existing at every level. So let's convert your challenges to opportunities through country-specific capacity based action for AMR control. Thank you very much and wish you all the best.
Thank you very much, Dr. Alma. Thank you for that beautiful presentation. Very quickly, I would like to invite Dr. Eba for a presentation. She has an engagement at 1 p.m. and she would like to quickly give a presentation in the next few minutes. She's a technical officer, One Health Emergency Preparedness and IHR. Thank you so much. The floor is yours.
Can you see my slides?
Yes.
Okay, fine. Okay, so thank you for the kind invitation to join this fruitful discussion on AMR. So today I'm gonna just shed the light very quickly on how we can really work all together and operationalize One Health for the AMR prevention and high-threat pathogen preparedness in Africa. So I think Dr. Amal and Dr. Bruno has already explained a lot about the burden of AMR and also about the drivers. Just to remind ourselves that unfortunately we have new estimates reveal that 39 million deaths are really expected to happen between now and 2050, and it's directly attributable to AMR. And when it comes to our region, the Eastern Mediterranean region, also unfortunately, we are the highest and most rapidly rising antibiotic consumption, maybe more than double of the global estimates, which really, not to scare you, but to highlight that it's a really escalating problem here in our region. These are the drivers for the AMR. And just to remind ourselves, as Dr. Amal and Dr. Bruno mentioned, that it's a really very complex problem. It has many axes, mainly around the human-animal environment interface. So it's not one sector problem. It's not one-man show. We have to work all together to compete all these drivers. That's why the One Health comes as the key solution, the golden, solution behind fighting AMR. Actually, when it comes to the One Health concept, it's not that old one in terms of the science. It's coined in 2004 in the conference One World, One Health. And you can search for the One Health concept. You can find a lot of definitions.
Excuse me.
It doesn't
your slides are not moving, and I think it's better to tell you now. So it's not really the presentation mode. So I think that you are advancing your slides, but they are not really advancing our screen. That's a pity because it's very interesting what you're saying.
Oh, sorry. I'm not sure why it does damage. So, could you see the global impact of AMR now?
Yes. If you pass it like that. No. It is.
This one?
Now it's okay. Yes, we can see that one. It's not in the presentation mode, but if you go through them like this manually, we can see how you move them.
Okay, so you can see the One Health concept slide now, right?
Now we can only see the global impact of AMR.
Oh my God.
So maybe
I don't know
go to
how
the
to
next one.
solve it. Could you see this one? It's not moving at your end?
No, not at all.
1 second. 1 second. Let me see how.
Do you mind sharing your slides from our end?
Let me check that. Yeah, you can do it from your end even. Let me pause, share, and then share it from your end. Yes, please. Yeah, number 4, I was explaining the One Health concept. Yeah, so I was saying that you can find a lot of definitions for the One Health approach. And here I just selected the latest one for the OLIP, the high-level expert panel definition, which define One Health as integrated unifying approach, which recognizes that the health of humans, animals, plants, and the whole ecosystem are really closely linked and interdependent. We used to apply the One Health at the beginning to prevent and detect and respond to zoonotic diseases. But by the application of the One Health approach, it has proven efficiency to cover even other areas, like the AMR, non-communicable diseases, vector-borne diseases, and all of these areas that need coherent collaboration and coordination across sectors. Next. So what does it mean applying One Health to tackle AMR? It means we, as a One Health professionals and all sectors, the human, animal, environment health authorities has to come hand in hand for the whole cycle, from starting from analyzing the needs, the gaps we are facing, the challenges, and design the plans, the appropriate policies, and till the implementation of these policies, plans, and programs. All of this, having everyone on board, all the sectors, all the partners, to solve all these, combined problem. As you can see from this figure and from previous presentations, it has many, many drivers that cannot be solved by one sector alone. Next. This also has been referred during the presentation of Dr. Amal, showing how the AMR has taken, concern and grabbed the attention of decision makers at the highest level possible. So starting from 2014 till now, every now and then we can see the AMR, has came to discussion of these policymakers. So as you can see from, no, you flipped already? Yeah. Mainly here we have the ministerial high-level conference in AMR that started 2014 and the last version in 2024. So 4 high-level ministerial conferences, focusing on AMR, focusing on the implementation of One Health approach. And the latest one, even they agreed to have an AMR One Health hub in KSA with support from WHO. And these two work on the capacity building for all countries to mitigate the AMR using the One Health approach. Next. From a technical perspective, the quadripartite, FAO, UNEP-WHA, and WHO had agreed to also work all together on this problem. And that's why they formulated a joint secretariat on AMR. And this joint secretariat has provided a lot of support, a lot of guidance to member states to tackle the AMR problem. And that's by developing, for example, you can go to the next one, the One Health Priority Agenda, Research Agenda. Next slide, please. So a lot of guidelines. One of them is the One Health Priority Research Agenda. And this guideline focusing on 5 pillars, which are the transmission, integrated surveillance, key interventions, also working on the behavioral insights and the change. And finally, we cannot forget about economics and policy as an important pillar to tackle AMR from a One Health perspective. In addition to this, there's also global database for tracking antimicrobial resistance country self-assessment survey. And for this, you can find one of the variables around the multi-sector and One Health collaboration and coordination that the country need to report on this. So these achievements, these initiatives really enforce the importance of applying the One Health approach in mitigating AMR. Next. When it comes to the implementation, specific details, specific activities, we can refer to our hero here, which is the One Health Joint Plan of Action. So this is also a quadripartite One Health global plan, and it has been, developed to cover 2022 till 2026, and has been developed in close consultation with the member states. The One Health GPA has 6 action tracks, which really interlinked with each others. And you can find here the action track 5 is mainly focusing on AMR to tackle it from a One Health perspective. Very detailed activities to the member states to take in to mitigate AMR from a One Health perspective is already in this detailed plan. Next. From a regional perspective, a lot of initiatives, a lot of activities has been taken and milestones. One of them is having this joint statement of intent that signed by the regional directors of the 4 regional quadripartite organizations. And this has 2 annexes or 2 commitments. First, the next slide, please. First one is endorsing and approving the regional quadripartite plan. Next slide. Yes, and this One Health Regional Quadripartite Action Plan has three main objectives. First is to implement a comprehensive regional One Health mechanism, and then also to efficiently and effectively use a One Health approach in the prevention control of health threats in the human-animal environment interface, and finally to promote the use of technologies, tools for the joint One Health practices. And all of this aims to enhance the human-animal environment interface, prevention and control health threats. Next one. This is the second annex that all the regional directors in our region has agreed to move on with, is to establish a One Health regional quadripartite coordination mechanism with different levels, with different rules and responsibilities for each level. So the first one is a regional One Health executive committee, which is the regional directors themselves are part of this committee, and then the coordination group, which represented myself and similar colleagues in the rest of the quadripartite regional organizations. And the third level is to formulate a One Health technical working groups for zoonotic diseases, food safety, and AMR. So these are the two main recent achievements we have, agreed as a regional quadripartite to move on with. At the country level, we are supporting member states as well to have a One Health structure, and this One Health structure will serve to support the countries to mitigate the health threats at the interface. So also to start with having a One Health steering committee representing decision makers in the countries from the three sectors, and then to have the secretariat or the One Health coordination committee, and then at the third level to have a very specific technical working group for each of these four thematic areas. And you can see here down, even we list here some of the TORs we support countries to elaborate based on the country context and needs. Next. In addition to this, we had a lot of activities, One Health related activities implemented at the country level. So we are supporting, as you can see, a lot of member states to develop their own national context, One Health, either national frameworks, operational plans, roadmaps that include capacity building, governance, and leadership, and how to coordinate and collaborate across sectors. Also, prioritizing health threats is also another activity that we are supporting member states to do so. Joint risk assessment of these health threats is one of the key activities that we are supporting member states to undertake. Even last week, I had this workshop undertaken in Yemen. Next. We expand also the support to the countries to have even a One Health curriculum, and this was achieved in Jordan for the professional staff at the Ministry of Health, Environment, and Agriculture, as well as in Egypt. Even for Egypt, Egypt is the first country within our region to have a One Health field epidemiology training. So this is to, again, focus on the operationalization of One Health, not being only a theory. So having all the professional staff working hand in hand in the collection of information on investigating the outbreaks, on the surveillance itself. So this is really a key beyond the operationalization of One Health. That's why we have also One Health surveillance information sharing workshop has conducted in Jordan. We supported many countries within our region to have established a multi-sector coordination mechanism with different working groups, with different tools, TORs, tasks, and responsibilities for all the concerned parties and stakeholders in the country. Also the IHR PVS National Bridging Workshop is one of the very efficient workshops that we implementing in some of our countries, also to bridge between the international health regulations and the performance of veterinary services to come up with a roadmap tackling the needs and the gaps for coordination into a very efficient, well-crafted activities specifically tailored for the country context. Next. Finally, the key challenges and needs for AMR from a One Health perspective. So we see it in our region is revolving around limited resources, fragmented health systems, financial constraints, and low awareness Really, these also hinder the AMR in our region. All these key challenges have huge impact on the surveillance, on the poor regulation enforcement, the lack of intersectoral coordination, and for sure, the adoption of One Health approach. From a One Health perspective, what we need to do is to work together to strengthen the health systems, improve collaboration, expand the education, public health awareness campaign. Next. Finally, as One Health focal point for WHO EMRO, I see it from a One Health perspective that the way out for these challenges is operationalizing the One Health. So starting from governance and leadership, you can just click to show the figures, please. From setting up the governance and leadership at the national and subnational level, from having all partners on the same table for the joint planning and implementation, from raising the capacity of the workforce. So workforce development is a key in this. Setting up the coordination and collaboration mechanism across sectors is a key, as well as finally information sharing across all sectors to be on the same page, understanding all the drivers of the problems and figure out how we can all move as a one entity to solve it is very important. Thank you. The last slide. Yeah, just to thank you for the invitation today. And also for your information, we had developed a One Health policy. We had 2 issues right now, and we are about to, issue the third one as well, who's focusing on, as you can see, the One Health coordination, zoonotic diseases, food safety, and AMR. Thank you. Over to you, colleagues.
Thank you so much, Dr. Eva. Thank you so much. So right now we'll be moving on to our 4th speaker for the day in person of Dr. Adilia Mia. She is the Senior Health Policy Advisor, ECPC Senior EU Affairs Manager. She'll be speaking on advancing sustainable AMR policies and governance frameworks for Africa's One Health response. Our biography will be posted in the chat box. Dr. Adilia, you're welcome. The floor is yours. Thank you.
Hello from Brussels, and thank you very much for the invitation. I hope you can hear me well, and I hope my slides move. I'm a pharmacist PhD, and I've been working in Brussels for about a decade now as Senior Health Policy Advisor. And antimicrobial resistance and also the One Health approach have been among my main focus areas. Today I'll be discussing about how sustainable policies on antimicrobial resistance and governance models, particularly those developed in the EU, can inform and support Africa's expanding One Health response. And a little bit I will also try to highlight my own contribution to the EU AMR policy progress. So you've already heard from previous speakers that antimicrobial resistance is not a distant or emerging threat. It is already costing lives. And the highest burden falls, unfortunately, on the low and middle income countries. And this is undermining modern medicine and also jeopardizing the progress of the Sustainable Development Goals. What it is important to point out here is that these global statistics frame the urgency of coordinated policy action. You've already heard about the burden of AMR in the African region, but all this that I tried to shortly list on this slide reflect systemic vulnerabilities, and I would like to emphasize that these are systemic vulnerabilities and not failures by clinicians or communities. And all these factors that you see listed here accelerate resistance and reinforce also inequities in access to effective treatment. You've already heard from the previous speaker speakers why we need a One Health framework. And I would like to emphasize here that resistant pathogens move between the three sectors: human health, animal health, and environment. And this also means that policies must regulate all three areas simultaneously, because fragmented policy cannot and will never be able to address a cross-sector problem. So at the EU level, the first One Health Action Plan was published by the European Commission in 2017 and consisted of three key pillars, namely to make the EU a best practice region, to boost research, development, and innovation, and also to shape the global AMR agenda. And these pillars illustrate how governance, investment, but also international positioning reinforce each other and offer also insights for the African regional harmonization. Now, so my work as a health policy advisor in Brussels began in 2015, when I shifted from research and academia to EU policy. And at that time, it was the Juncker Commission, and it was very little political will to advance health legislation at the EU level. Actually, this was the only EU mandate where no new strategies were adopted in the field of health. And pressure from the pharmaceutical industry definitely contributed to this lack of action. So it is also important to note, for those of you that don't know, that the EU has clear competence to legislate on veterinary medicines, but human health policy largely remains a national responsibility. So the EU can only legislate on cross-border health threats. However, as already pointed out by a previous speaker, WHO has declared antimicrobial resistance a global health threat, and it was clear that also the EU needed to act on AMR in human health. I was already in Brussels for 2 years and a bit, and I became increasingly dissatisfied with the absence of progress from the European Commission. I started to collaborate with a coalition of EU health NGOs, and we partnered with several members of the European Parliament, MEPs, to draft a resolution calling on the Commission to legislate on AMR in human health and also to develop a comprehensive legislation. The key challenge at that moment was to secure a majority in the Strasbourg plenary. So therefore, in September 2018, one day before the vote, I was invited to speak in a press conference in the European Parliament in Strasbourg and to convince the MEPs to vote for this report. And the media played an important role. You see in this slide an article from the Telegraph that quotes my speech from that time. And luckily, the next day, the Parliament adopted the report with a high majority. So following this, let's say, achievement, I decided to stay in Brussels and not go back to my academic life and continue my work in EU health policy and advocacy. Some EU countries in the recent years prioritize AMR and put it high on their political agendas while holding the presidency at the EU Council. And this is important because this pushed things further in terms of legislation at the EU level. And it's the case of the Bulgarian presidency in 2018 that came with concrete recommendations to reinforce the ban of antibiotics as growth promoters and also limiting prophylactic and metaphylactic use and allowing certain antimicrobials to be reserved only for human health. Then in 2019, the Finnish presidency pushed member states to adopt national action plans, strengthen surveillance, improve infection prevention and control, restrict veterinary antimicrobial use, and also raise public awareness. And finally, in 2023, the Swedish presidency set the EU's 2030 targets for reducing antibiotic consumption, namely 20% reduction in the total human antibiotic consumption, and a 50% reduction in the overall EU sales of antimicrobials used in farm animals, but also in aquaculture. What we actually learned from the presidencies of the Council was that governance, so effective AMR strategy, requires coordination across ministries and not just across health authorities. And you've already heard from Bruno about the EU banning antibiotics as growth promoters back in 2006, and actually EU was the first region to do so. And this measure was later reinforced by the Regulation 6 per 2019 on veterinary medicinal products, which strengthened supervision. This actually set a precedent for antimicrobial stewardship in agriculture, and also showed how regulatory action can transform market practices. And I believe that Africa can adapt similar approaches to the African Union Inter-African Bureau for Animal Resources, and also to the regional economic communities. And following the vote that I mentioned in Strasbourg in 2018, the European Commission didn't decide to come up with just one legislative piece on AMR in human health, but actually to include articles on AMR in human health on the all upcoming legislative pieces for human health. And one such legislation is definitely the EU pharmaceutical package that is now in trilogue between the Parliament and the EU Council, and that has major relevance for AMR. And why I say this? Because this package, consisting of a regulation and a directive, proposes clear incentives for novel antibiotics, comes with stronger environmental risk assessment demands, and also faster access to critical antimicrobials and improved surveillance obligations. And this package will shape definitely the EU AMR policy for the next decade, and also offers useful policy models for Africa's regulatory evolution as well. Another relevant legislative piece is the very recent published Critical Medicines Act, a regulation that identifies antimicrobials as critical medicines and focuses on strengthening the supply chain resilience, and also on reducing the import dependency and supporting regional manufacturing and improving stockpiling and forecasting. And I think Africa faces similar vulnerabilities. So understanding how all these mechanisms work can actually provide strategic references for the regional adaptation. Veterinary and food system policies also play an essential role in AMR control, and EU measures in this sense include, besides the ban as growth promoters, the veterinary antimicrobial monitoring systems that I will describe a bit later, the reduction targets under the farm to fork strategy, and also some biosecurity frameworks. And all these together demonstrate how AMR stewardship extends beyond hospitals and into the food production and animal health systems, an area where also Africa can build regional alignment. Important to point out here is the fact that the environmental sector is often the most overlooked dimension of AMR, unfortunately. And the EU has recently advanced wastewater surveillance, has regulated pharmaceutical discharge, and introduced also effluent rules for hospitals and industry. And I believe that strengthening environmental monitoring will also be essential for Africa's One Health governance progression. At the EU level, started in 2024, we have an important joint action on AMR, the GEMRI, that serves as the EU's implementation mechanism for AMR policy. And this joint action focuses on improving governance, enhancing surveillance capacity, and also supporting member states' national action plans, while also promoting prudent antimicrobial use and strengthening awareness and professional training. And this demonstrates how collective capacity building can actually accelerate national progress. And what can Africa adapt from the EU? There are several elements that I tried to list in this slide. Well, first of all, regional coordination, the multi-sectoral AMR committees, the cross-sector surveillance networks, the medicines regulatory harmonization, and also stewardship frameworks. And I want to stress on the following point. It's adaptation and not replication that is crucial here to ensure alignment with the African institutional realities. Because adaptation means tailoring to local health systems, it means political structure, and it means economic realities. Taking some aspects in this slide into details, well, you've already heard about strengthening stewardship and why this is important. And I want to add here that stewardship fails when leadership and accountability are missing. So governance structures must support implementation. You've heard already from Bruno about the importance of vaccination, and I don't want to repeat this aspect. And from the surveillance, that is the foundation of the AMR response, what we have here at the EU level are these networks coordinated by the European Center of Disease Prevention and Control, the so-called ECDC, that monitor and where member states have to report on infections for human health, on consumption of antimicrobials in agriculture, and also on the food and waterborne diseases. And why this is important? Because by gathering data, we actually have the size of the problem. And when we have the size of the problem, we must find the solutions to address problem. And Africa definitely will need scalable and cost-efficient models as well that prioritize interoperability and also data sharing. Medicines quality is also a very important point. And I must say, Europe has quite strict regulatory oversight. However, in Africa, it is important to strengthen medicines quality, and this requires regulatory harmonization via the African Medicines Agency, and also regional blocks, stronger GMP inspections, and also improved procurement standards, because poor quality antibiotics will accelerate resistance faster than the misuse alone. Another important point at the EU level is definitely the R&D. We have at the EU level innovation frameworks like Horizon Europe, and also the Innovative Health Initiative, that is a public-private partnership. And all of these offer lessons in stimulating antibiotic R&D, and these models also present opportunities for an African EU collaboration, for technology transfer, and also for joint funding mechanisms, particularly for diagnostics, but also for vaccines and others. Sustainable AMR policy requires multi-sectoral coordination. You've already heard this from previous speakers, and clear roles and accountability are important. Then there is a need for reliable financing, for transparent reporting systems, and for meaningful involvement of the civil society and also of patients. And governance, more than science or technology, is often the missing ingredient in the national AMR plans. What are my key recommendations for Africa? Well, definitely strengthening the regulatory alignment, investing in surveillance capacity, scaling stewardship programs, but also improving medicines quality control, enhancing environmental monitoring, and ensuring that political commitment happens both at continental and at national levels. And to conclude, I would like to strengthen that AMR is a cross-border, cross-sector threat that requires coordinated One Health action, and that EU policy experience offers several models that Africa can adapt to build resilience, to build a resilient AMR governance. But its strong regulation, its surveillance, its stewardship, and investment that are essential to reduce the AMR burden and to safeguard the health system. So political leadership is the one at the end of the day that will determine the pace of the progress. And with this, I would like to thank you for your attention. I look forward to your questions and to continuing the discussion. And I'm also willing to support the work of GET Consortium. Thank you very much.
Thank you so much, Doctor. Thank you very, very much. We truly do appreciate you. And thank you for listing the way, mentioning how Africa can adapt and not replicate things from the EU to curb antimicrobial resistance in the region. So thank you so much. Right about now, I'll be moving on to the final speaker for this webinar this afternoon rather, in Nigeria. And if you're just joining us, thank you for joining. Please introduce yourself in the chat box, your name and wherever you're joining from. Also, direct your questions to the Q&A box. It will be addressed at the end of the session. So I would like to invite our final speaker for the day, Dr. Afnish Amir. She's the Project Director, AMR at the US CDC project, NIH Pakistan, and she'll be speaking on strengthening One Health AMR surveillance systems, lessons from low resource settings. So thank you so much. Our biography will be posted on the chat box. The floor is now yours. You can now unmute your mic. We sincerely apologize about that.
Yes, now I can. I'm really sorry. I was not able to unmute myself and was not able to put up my screen, but now I'm here. I think you can hear me well.
Yes, we can.
And the screens, can you see it moving? The slides?
Yes, it is moving.
Okay. Thank you so much for the invitation, and thank you so much for having me over here to discuss something really relevant in the current scenario. And I'm really thankful to all my previous speakers for setting the good stage for me. And I'm going to share some of the experiences by working in the LMICs, that what should be the best solution for strengthening the One Health AMR surveillance systems. Much has already been discussed. Some of these ideas that I can share right now over here. So the question is that why surveillance matter? Why are we focusing this much on the aspect of the AMR surveillance and the integrated surveillance? This is one good example for that particular scenario. In 2022, from Pakistan, one of the cases has been reported that shows that Salmonella typhi in Pakistan, they have shifted from susceptible to NDM5 carbapenem resistance. And this is something really alarming. This is the first case and only case in country right now. But a robust surveillance and active surveillance at the institutional level was able to pick up this particular case. And this was further confirmed through the whole genome sequencing as well. So this is a threat we could have missed without having a strong surveillance. And this is the need of the hour, actually. The pathogens, they are gaining the resistance, acquiring the resistance mechanism very rapidly. There are a number of factors contributing to it, like the climate change, the tourism, the travel, and the exchange between the different countries. The people are moving, and the pathogens, they are also going from one place to the other. So that all requires a very strict vigilance, a strict eye, so that we can have an understanding what is happening in the trends and patterns of the pathogens and what should best be done to control or to do some preventive measures. So for AMR surveillance status, currently right now, this is the map from the global database for tracking antimicrobial resistance country self-assessment survey, the TRACK survey. And we wanted to have an understanding that what is the current national surveillance system for AMR in human health sector. And here you can easily see that there are only few countries are left which are marked as red. A in the block that shows no capacity for generating the data. Very few are in the orange color, which are showing that data is collected, but again, it is again at the local level. And C are all the countries which are collecting the data to the national level, but national coordination mechanisms, they are still lacking. And in the green color D, light green color, you can see that majority of the countries, they have established a good surveillance system, which is nationally organized, and there's a good coordination mechanism, and reporting is being done and disseminated to all the levels. And CE are those countries where we have seen a very robust response towards the antibiotic utilization and consumption as well. So this is the whole picture of the country. This was the map from the very recent track study in 2020-25. So the different models for the surveillance system that are being adapted, particularly in LMICs, it is basically the lab-based surveillance, and all the surveillance mechanism SOPs, they are following the standardized AST methods using the CLSI guideline or the UCAST guidelines. Mainly the Sentinel site network system approach is being used for the lab-based surveillance. There's a national reference laboratory, and then there's a network of the Sentinel sites which are sharing the data, quality data, to the national center. The national center is playing the role in terms of providing the quality management system trainings and also the external quality assurance assessments to have an understanding of the quality of the data that the sites are sharing. And then there is a specimen referral system that is being established by the National Reference Laboratory to assess the provincial reference laboratories or the Sentinel laboratories for the data sharing. When we talk about the epidemiological surveillance, it is being done. There are case definitions for particular priority pathogens or priority infections that are being identified. And then there is an outbreak reporting. Whenever there's an outbreak, there's a follow-up on the outbreak. There is always a approach that is being utilized in many of the countries. It's the integrating the AMR systems with the existing surveillance models like the IDSR and DHIS2. Always helpful to leverage on the existing system so that there is no duplication of efforts. One Health, much has been discussed previously in the slides. This is the need of the hour, where there's always a connection between all the three sectors. And one good example is the Tricycle project that has set the standards in almost 6 countries in the EMRO region. And we have seen that from the same catchment population, we were trying to identify the prevalence of the E. coli. And that has given us some understanding that how the pathogen is transmitting between the three sectors. Challenges, we are all very well aware in the low resource settings. There is always a challenge for the overburdened health facilities, and associated with it is the laboratory capacities, which may be limited. In many of the low resource settings, countries in particular, in bigger cities, we have seen laboratory capacities, they are much established as compared to the laboratories in the district level or the primary healthcare level. The quality testing is again a big issue in some of the countries as well. The fragmented data sharing mechanisms, that is a big challenge for the AMR surveillance. The data is being generated but not communicated at the different hierarchies and not able to being translated to have a true picture of the burden. Then funding, financial aspect is always being discussed. Amal has just shown the slide on the ANGA commitments. There is a huge discussion towards the access towards the diagnostics and therapeutics in LMICs and generating the funding mechanisms for these countries. Without the good funding, we won't be able to have a good diagnostic facilities. Similarly, weak governance and regulatory frameworks. There are regulatory mechanisms, but they are not being implemented to the grassroots level, which can be a challenge. And then human resource gaps in terms of the availability of the trained microbiologist, epidemiologist, and the data analyst. Some of the strategies that I have gone through this experience working in many countries, there is always suggested to go to a phased-wise approach and always prioritize the surveillance model. There may be dearth of the resources to start at once at all the levels, but it is always suggested to start with some priority pathogens, to target few pathogens based on the country needs, and then always select high yield sites, so either tertiary care hospitals or the ICUs or some pediatric settings based upon the current prevalence of the disease burden, and then gradually expand to the other countries. Similarly, sentinel surveillance network, that can be a very best approach to have a gradual expansion and engaging the sites in a stepwise manner. It is a very cost-effective alternative solution to the nationwide coverage, and labs should have a good quality data generation and always try to leverage on the existing vertical programs like the tuberculosis, polio, and influenza. It is suggested to always provide or discuss on the SOPs which are simple, which are low cost. This can help the tertiary care laboratories or the sentinel laboratories to perform the testing accurately and to perform the testing according to the SOPs. And in case of the advanced testing is required, there should be a referral mechanism that should be developed, and the samples can be shared with the provincial reference laboratories or the national reference laboratories. Public-private partnership always encouraged, because the private laboratories or the healthcare setups, they must have developed many good system within them, and leveraging or engaging them in the national systems would be always helpful for the generation of a good quality data. Genomic surveillance is a much appreciated approach for the AMR surveillance, but the constraints of high cost is always there with the genomic surveillance. So in this scenario, a referral system is always suggested. Any new case or any emerging pathogen that can be seen at the sentinel site laboratories, that can be shared with the National Center for the Genomic Testing. Further recommendations always suggested that the strong governance and a coordination mechanism is required. Many of the times the governance, the organograms are being developed, but there's a lack of coordination, which breaks the motivation and the chain of transmission of the data at different hierarchies. Policy frameworks and SOPs should be developed. Financing models for sustainability. We have seen the approaches, the support from the donors, from the stakeholders, but eventually the country should be owning the system and should be generating the funding for the AMR systems. Parallelly, workforce development training is required. Data management and use, try to rely on the existing data management system like the WHONet, DHIS2 systems. There should be a data analysis and visualization dashboards. Open source data should be open source. People should be able to see what is happening, and they can interpret according to their needs. The data should be reporting at the national level and the international level as well. Much needed is that this is a high time that all the data should be moving towards the clinical stewardship. The clinicians should be made well aware about the data that is being generated. They should be made well aware on the trends and patterns of the pathogens, and this is the best way of turning data into the action. So just the last slide. From the low resource settings, it is always suggested to have a sentinel site laboratory network system for having a quality data system, and always supporting the sentinel laboratories for the quality management systems. Data system and data management should be strengthened. Integrate AMR surveillance from a One Health perspective, engaging all the three sectors. Most important, all the data should be used for the stewardship purposes, and then we can leverage on the donor funding, but existing infrastructure and also the national systems for generating the funds should be promoted. So with this, this is the last slide. I stop over here. Thank you so much.
Thank you so much. Thank you very much, Dr. Amir. Thank you for that highly informative presentation. And thank you for highlighting the recommendations and the things we can follow to ensure we have a strengthened AMR surveillance. Right now, we'll be moving on to the interactive session and the Q&A segment. But before that, I would like to mention a few things that we've discussed today, right from the first speaker, how we mentioned that antimicrobial and microorganisms, this is not the first time we are hearing of them. They've been in existence right from the onset, even before our own very existence. And he also highlighted how Africa carries a higher ratio of antimicrobial resistance in history. Also, we moved on to the Quadripartite Action Plan, and we talked about what organizations are doing and the relationship between antimicrobial resistance and the One Health approach. We also mentioned how Africa can adapt the EU strategies without replicating what they do exactly. We adapt it to our own local challenges and our economic realities. Also, we mentioned and we're given some recommendations on how we can strengthen antimicrobial resistance, which includes strong governance and data management. So a big thank you to our speakers. We do really appreciate you. And right now we'll be moving on to the question and answer. And I can see we have quite a number of questions here. The first question is, what can we efficiently do for AMR threat? I don't know if anyone wants to answer that. What can we do for AMR threat? The floor is open to our speakers.
Can you repeat the question, please?
What can we efficaciously do for AMR threat? I don't know if you get the question. I could paste it in the chat box. Just a minute. Yeah. And also, while you're on that, what are your recommendations? This is to Dr. Bruno. What are your recommendations to implement as soon as possible?
Well, I think that we all talked about the possibility to tackle antimicrobial resistance threat. And as we have seen, I think there are many different levels. We have seen very well how we have the political level where we have to organize intergovernmental and multidisciplinary actions. But I don't know if the question is more on the individual level. What can we individually do, which is also something that we are always interested. So there's one level is the governors, the others are the policymakers, the other one so WHO and the governments. Then there's the prescribers, so the ones that are handling antibiotics, which is the vets, odontologists, and dentists, and medical staff. And then there's the end users. So maybe if this is related to end users, obviously to keep your vaccination schedule tight, kids' vaccination schedule, and also we are now recommending the vaccination throughout their whole life. So not only vaccinating children, but also vaccinating the elderly people, because that reduces the disease and that viral and bacterial. And with that, we also reduce antibiotic use. Also, when there's a course prescribed for humans and for animals, that we finish the course exactly as it was prescribed by the doctor or by the vet. So even if we feel better after 5 days, that we finish the course completely. And the other one is that when we don't use automedication. So it's very, very classical that we have been already prescribed a specific medicine, and then we say, well, this was the same medicine that I got last time. I will use the same. No, to go again to the doctor or to the pharmacist or to the vet, and to see what antibiotic you use exactly for that. If you need an antibiotic for that specific disease. So as for the end users, it's that. For the prescribers, it's to prescribe only when you have bacterial diseases and not viral diseases, or never prophylactically, and that it holds true for human and for animal medicine. And for the policymakers, obviously, to do as much as possible that there's this One Health approach, and there's transdisciplinary talk and effective governance and between human sector, animal sector, and the environmental sector. This would be maybe very broad recommendations for what we can specifically do. I don't know if somebody has something else to add. Probably yes.
Thank you, Dr. Bruno. I don't know if our other speakers have something else to contribute, or we'll move to the next question. So the next question we have is, how can African nations effectively bridge the implementation gap current national action plans and practice by aligning cross-sectoral governance, integrated surveillance, and sustainable financing to strengthen the One Health response to antimicrobial resistance? I could take that again and also paste it in the chat. How can African nations effectively bridge the implementation gap between current national action plans and practice by aligning cross-sectoral governance, integrated surveillance, and sustainable financing to strengthen the One Health response to antimicrobial resistance? I don't know if any of our speakers want to answer that.
Maybe I'll try to summarize this, because I spoke about these aspects a little bit in my presentation. So what I see for Africa is three-step action. First of all, the need to strengthen the cross-sectoral governance with a real authority. And why I'm saying this? Because many countries already have multi-sectoral AMR committees, but they often lack a legal mandate. They often lack proper budgets or the authority to coordinate across human health, veterinary services, and the environment. And if there are African countries that perform better, they can establish a formal One Health coordination mechanism that must be anchored in the political level, at the, I don't know, prime ministers or cabinet office, because otherwise, without a political will, it's not going to happen. And this will give the AMR agenda political weight and ensures that the ministers will follow common priorities and help align with the projects. Then another important point is the need to build integrated surveillance systems that are phased and also realistic for Africa. And instead of attempting from the beginning to have nationwide surveillance systems, countries can start with some pilot projects, both for human and animal health, and they can use some lab protocols and also digital reporting tools. And I think the key here is interoperability, because even simple and harmonized data flows can provide actionable evidence for stewardship, for procurement, and also for infection control, which are key to tackle AMR. And then my third point that I see here is securing a sustainable and, let's say, blended financing mechanism. Because the national action plans, where they fail is mainly because they are unfunded. If they are just nice on the paper, but money is not allocated to fund them, they are not going to happen in reality. So countries definitely need some small budget lines for AMR coordination and surveillance, and even modest ones. at the beginning just to demonstrate they own the plan and they are able to implement it. And of course, this can be combined with different donors that can support the plans. Maybe governments can chip in. And I think pooling funds through the National Health Security accounts or the One Health investment plans can reduce the fragmentation and increase the predictability. So I think that, just to conclude, the implementation improves when governance and when surveillance and financing are planned together and not separately, and the political commitment plus the pragmatic and step-by-step capacity building is what actually allows countries to move from plans to something that happens in real time and in real life.
Thank you very much. Yes, Dr. Bruno, one of our speakers also mentioned that instead of pointing blames, we need to start working together, which is the One Health approach. All sectors need to put heads together and work together to achieve that one goal of curbing antimicrobial resistance. And right on to the last question rather, for the day. And this would go to Dr. Amil. Says, what are the concrete actions implemented and followed? What are the concrete actions implemented and followed? I guess she mentioned it during her presentation, or she could also, if you don't mind, you can also re-emphasize it. Thank you.
Hi, I can answer this question, that what concrete actions that are being followed right now, if I can, yeah, exactly. So, Faith, what we have seen over the years, that for the last 10 years, there's a huge momentum, huge discussion related to the AMR. And we have seen that the surveillance angle has been implemented a lot. In all the LMICs from Africa to Asia, we have seen that there is a much investment towards the antimicrobial surveillance. And there is much investment towards the enhancing the laboratory capacities for generating the quality data. So that is one good angle that we have seen through the investment of the many stakeholders, including the Fleming Fund. We have seen that there is a huge change towards the surveillance. The data is there, and countries, they are contributing to it. So this is one action area, and again, awareness. Lot of awareness has been created, both at the United Nations, both at the international platforms, global platforms. IPI is going to be established. Ministerial meetings are being held. So there is a lot of awareness and advocacy that is being done. And the need is now that we have to translate all this awareness, all this data into the actions. And the main action areas are the clinicians, are the community. To the clinicians, the stewardship activities, they are being suggested and they are being promoted in some of the countries. But for the community itself, still we feel there is a big gap and that needs to be fulfilled. We have seen that there is a lack of the social sciences in the antimicrobial resistance to generate the right message for the community so that they can adapt to the practices of the antimicrobial stewardship. So some of the angles that are being targeted, but now it requires that this data needs to be translated. And again, now the actions should be multitask, like it should be done at once at different angles, because now the problem is getting much serious over the years. So I just stop over here. Thank you so much.
Thank you so much. Yes, I totally do agree with you. One of the actions we also take, like you mentioned, is the community, and we're also glad to inform you that GET has a project called the Get One Health School project that focuses on introducing the concept of One Health to students in Africa, starting with Nigeria. And recently, we just concluded an outreach visiting secondary schools in Oyo State, Nigeria, teaching them about antimicrobial resistance and teaching them proper hygiene, what the steps to take to prevent antimicrobial resistance and drastically reduce it, how they should not do self-medication and things like that. So yes, community is quite a very good way to implement all these strategies. So thank you so much. A big thank you to a big thank you to our speakers. I don't know if they have one last word, maybe closing remarks to say before we bring the webinar to a close. Does any of our speakers have anything to say?
I wanted to say something. Can you
Please
hear
go
me?
ahead.
Yes. So I want to underline the importance of social sciences. So there's a lot on educational sciences, communication sciences, behavioral sciences. So in the One Health concept, it's not only vets and doctors working together and environmentalists working together. It's much more. So we really, and I fully agree with what was just said, that we have to include behavioral scientists. It's really behavior that we need to change in the policymakers, in the society, and in the prescribers, and also sociology, anthropology. There's a lot that is relying also economists, as was said, just to implement also and to stimulate the development of antibiotics. So social sciences is something that we've left a bit apart from this important health problem, and it's very important. We're embracing it very much now, and I think it's very important also to make the message pass to the real people that are finally have to take the decision for the automedication, for prescribing differently, etc., etc. So welcome social scientists in the One Health.
Thank you very much for highlighting that. Thank you so much. Dr. Adelaide, do you want to say something?
Well, on my side, a successful approach to tackle AMR is definitely a holistic one, and collaboration is key. But I think an important point that we didn't mention today is definitely investing in health literacy. Because without health literacy, if patients are not on board, it's not going to happen. And I think this is key, and this is something that is left behind in most of the action plans.
Great, thank you so much. Thank you. We truly do appreciate our speakers. Using the clap icon, please let's put our hands together for our speakers, appreciating them for their time. They've been with us for the past 2 hours, and that's quite that's a lot, considering the fact that they are busy fellows. Thank you so much. We appreciate you. And now, concluding on today's webinar, we appreciate our speakers once again. Thank you for your time, your expertise, your commitment, and thank you to our participants. Like we usually say, we do not have a GET webinar series every month without the participants. We organize this just because you are right here. Thank you for being an active part of the GET community. Thank you so much. And before we go, we'd also like to say that certificate of participation will be issued to all registered participants. And you can also stay connected via our social media platforms at GET Consortium and our website at www.getafrica.org. Also, we do have a journal that you can publish your original research articles for free at www.getjournal.org. You can visit the website for more information. So we have now come to the end of this webinar. Thank you so much. We appreciate you. Bye. Thank you. See you next month.
Thank you. Bye.
Okay,
Bye. Thank you.